Morning, good afternoon, or good evening, depending on where you are joining us from today around the world. And welcome to this webinar on mass vaccinations, protecting the world. I'm Siobhan Bonita. I'm a former UK senior civil servant, and I'm delighted to be hosting this webinar on behalf of the Publishing House Global Government Forum that serves civil servants all around the world. And I'd also like to thank our knowledge partner today, UiPath. Now, in terms of today's topic, the development of effective vaccines has provided the world with paths out of the COVID-19 pandemic. But until enough people around the world are vaccinated, real risks still remain in terms of new variants and outbreaks. And this means that national governments can't exclusively just focus on vaccinating their own populations. They also have a direct interest in supporting the global vaccination rollout. And even within countries, vaccinating an entire population is a huge and complex task. Public servants working with the private sector have had to secure supplies, create distribution networks, decide which groups to prioritize, and tackle vaccine hesitancy and misinformation. And all of these issues are even harder in countries that lack health and transport infrastructures or the buying power to compete for vaccine supplies in a global market. At this webinar, civil service leaders and external experts will discuss different aspects of the global vaccination response. How have nations and officials addressed the challenges? What worked? Where have we fallen short? And what lessons can we learn that might help us with a future pandemic? Now, in a moment, I'm going to introduce our amazing panel. We have a truly stellar global international panel with us today, and they're going to give some opening comments. But we will allow for time at the end to take as many of your questions from the audience as we possibly can. So on whichever device you are using, there should be a Q&A function at the bottom of your screens. Please, at any time throughout this webinar, send in your questions using that Q&A button, and we will get through as many of those as we can before the end of the webinar. Without further ado, I'm going to introduce this brilliant panel. So first, we will hear from Jessica Hammer. She's a research fellow at the Centre for Universal Health in Chatham House here in the United Kingdom. She has worked in global health for 12 years on issues including health financing, inequality in health, and access to medicines. And prior to Chatham House, she worked at a number of NGOs, including 10 years at Oxfam. Then we'll hear from Professor Leo Yi Sin, who is Executive Director at the National Centre for Infectious Diseases in Singapore. Professor Leo has led her team through multiple outbreaks in Singapore, including SARS in 2003, pandemic influenza in 2009, Zika in 2016, and multiple surges of dengue. She has published more than 300 scientific papers and has won numerous prestigious awards for her work on infectious diseases. Then we will hear from our knowledge partner, from Lisa Webber, who is Industry Practice Senior Manager for Healthcare at UiPath. And with 25 years in the healthcare industry, Lisa has led and managed both hospital and physician practice networks from an operations perspective. Now, having been with UiPath for 3 years, she works to highlight the value of automation within healthcare. So it'll be really interesting to get that different perspective. Then we'll head over to the Philippines to hear from Dr. Maria Rosario Vergere, who is the Undersecretary of Health in the Public Health Services team at the Department of Health in the Philippines. And she's also the official spokesperson for the department. She's held a number of senior roles in the health department and wider public sector. And aside from public service, she's also committed to nurturing the next generation of public health leaders, serving as a faculty member at the Development Academy of the Philippines. And then last, but by no means least, we'll hear from Heather Deehan, who is the Executive Director for Vaccine Logistics and Operations in the Vaccine Rollout Task Force at the Public Health Agency of Canada. Heather dedicated much of her career in Canada to supporting primary care in remote and isolated settings. She has held leadership roles in pandemic preparedness and response, most recently heading the COVID-19 National Vaccine Logistics and Distribution Programme. Previously, she worked at the Vaccine Centre for UNICEF, based in Copenhagen, supporting immunisation programmes to over 100 countries. I honestly can't remember a webinar where we've had a panel of this caliber. So as I said at the start, please do use that Q&A function on your computers to send in questions so that we can really maximize the expertise that we have with us today. Now, without further ado, I'm going to invite Jessica to give us the opening presentation.
Okay, thanks very much. Can everyone hear me okay?
Good for me. Thanks, Jessica.
Brilliant, thank you. So I'm going to kick us off really with the global picture of the vaccine rollout. And as the title slide says there, unfortunately, it is a picture of enormous inequality, and it's been termed a vaccine apartheid by many. If we can go to the first slide, please. So as we know, progress in many ways has been remarkable. In terms of a year ago, we were just having candidates under development, and now 6.5 billion doses have been administered worldwide. But these figures mask enormous inequality in access to the vaccine. So you can see from the image there where the concentration of vaccine distribution has been and where the lack of vaccines is today, and especially you can see it's in sub-Saharan Africa. Next slide, please. So the statistics really speak for themselves here, but of those 6.5 billion vaccine doses administered globally, the majority have been in high-income countries and upper middle-income countries. So 62% of people have received a dose of vaccine in high-income countries, whereas in low-income countries, that becomes just 2.7% of people, and fewer than 1% have been fully vaccinated in low-income countries. It's estimated that G7 and EU countries will have 1 billion more vaccines than they need by the end of 2021, and that an estimated 241 million of these will go to waste by the end of the year. And that is actually factoring in making provisions for booster campaigns and vaccinating the over 12s at least. The global vaccination target for the end of the year set by WHO, which was to have 40% of the population in lower income countries vaccinated, is likely to be missed in 67 countries. And more than 50 countries already missed the very unambitious target of fully vaccinating 10% of their populations by the end of September. COVAX, which is the main multilateral mechanism to supply vaccines to the world, has shipped 371 million doses, but that represents just 5% of doses administered worldwide. It secured a lot more, but in terms of what's been delivered, it's just 5% of the total. It's perhaps worth saying on COVAX that the vaccine supply has been choked up by a number of factors, including wealthier countries buying up the majority of available vaccines through bilateral deals negotiated much earlier in the pandemic, export restrictions, and it's faced its own challenges around governance and other design flaws. But a further fundamental problem behind the inequality we see today is the finite level of supply and production capacity we have for vaccines in the world. So it's really a zero-sum game. Next slide, please. So this shows just another depiction of the doses delivered and that vaccine inequality. I don't know how well it's visible even on screens, but the blue line at the very bottom of the graph there represents low-income countries' share of vaccines delivered. Next slide, please. So, and yet, we know that this current situation is not only driving massive death and suffering, it's self-defeating and makes absolutely no sense in terms of ending the pandemic for everyone. The mantra, no one is safe until everyone is safe, has been often repeated throughout the pandemic, but it remains absolutely true. Currently, we're seeing the dominance of the Delta variant and how much it's driving a huge spread and mortality burden. So, for example, it's estimated that 40% of deaths from COVID in Africa have occurred since August this year. We also know the ongoing economic losses of the pandemic are vast. So we have the IMF predicting recently that we could see global economic losses of 5.3 trillion by 2026 if the pandemic continues without further intervention. And we know that the global vaccine market itself has expanded enormously, delivering record profits for some companies and set to expand to 124 billion next year, despite the huge public funding that's gone into vaccines. So vaccinating the world makes absolute sense, but the next question is what needs to change to accelerate this and see it achieved? Next slide, please. So what can be done? The first immediate step is on sharing of doses. This is an immediate short-term measure. We've had over 1.2 billion doses pledged by mid-2022 by G7 and EU countries, but just 12% of those delivered to date. So we really need to see those pledges fulfilled. But we need to go beyond this to meet the needs that are very much there and avoid vaccine wastage in a time of chronic scarcity elsewhere. So if G7 and EU nations share the 241 million expected unused vaccines at the year end that we've already come across, we could meet the mid-2022 vaccination target set by WHO, which is to vaccinate 70% of lower income countries' populations. Secondly, we need to finance the response. So the ACT Accelerator, which is the umbrella mechanism for the global COVID response, including COVAX, the vaccines pillar, has the ACT Accelerator, has a shortfall this year still for 2021 of 15.8 billion. And in 2022, we're waiting to hear the expected budget and forecast, but there's an estimate I've seen of 20 to 25 billion US dollars further needed. But these are very short-term, small investments compared to that 5.3 trillion of losses forecast by the IMF. Thirdly, we need to transfer technology. So we've had calls made and mechanisms established to really expand global production capacity and build manufacturing capacity in regions for the long term. We've seen a few bilateral limited arrangements today, contracting out production, etc. But there is a need to go far beyond this to solve the issue of a finite supply of vaccines, which is massively outstripped by demand and has seen access determined in this very unequal way. So for example, we've had WHO establish an mRNA vaccine hub in South Africa with expected royalties and etc. But engagement by originator companies has been fairly limited today. Finally, there have been calls made to waive patents and other intellectual property barriers on vaccines and their production for the duration of the pandemic. And that's to remove the hurdle to expanding production, which patents and intellectual property presents. So we've seen a proposal to the World Trade Organization calling for this, has the backing of 105 countries and goes beyond vaccines to cover treatments and diagnostics too. And there's growing momentum behind this. I noticed even Pope Benedict in the last few days has called on the great pharmaceutical laboratories to release the patents, excuse me. And then finally, we need to improve transparency. So that's an additional call really for companies to make clear their pricing and delivery plans to enable countries to compete and to prepare effectively for their rollout. So I'll look forward to the discussions, but I'll stop there. Thanks very much.
Thank you so much, Jessica. I mean, it's a very good way to start, but quite a sobering way to start. You've highlighted there very effectively the huge inequality in terms of the global rollout, the focus on the need for, as you said, the mantra, no one is safe until everyone is safe, but what does that mean? And your kind of real call to action at the end there in terms of just serious collaboration required amongst different nations, and not just on sharing doses and money and resources, but also in things like the technology and the patents and waiving some of those things. So thank you so much. A very sobering but very much needed opening presentation. Thank you, Jessica. Professor Leo, I'm going to invite you now to give your presentation.
Thank you. Good morning, good afternoon, and good evenings to everybody. I'm Isan from Singapore. So I will give you an updates about the situations in Singapore. Singapore is among the first few countries in Asia to import the early cases of COVID-19 into Singapore. The first case arrived in Singapore in January 2020. For the entire year of 2020, because of the very strict containment strategies that put together by the Singapore government, we saw very few number of community transmitted cases. The outbreak was largely driven by the migrant worker in Singapore last year because of the dormitory setting. So at the end of last year, we have a cumulative total of slightly lower than 2,500 cases. And Singapore is also one of the countries that adopt vaccination campaign very early. The first dose of COVID-19 vaccines was given in December 2020. And the government strategy at that point in time was to go ahead to vaccinate healthcare workers, as well as the vulnerable populations, including the older populations. So in this year, however, we see a very different patterns. This year, we saw the arrival of Delta variant into Singapore in the month of April. And soon after that, we had a significant community transmissions. And today we continue to see large number of COVID-19 cases in Singapore. Our average reported daily cases hovering around 3,000 over cases. About 300 cases to 400 cases require oxygen therapy in the hospital setting. As of now, we have a cumulative total of 239 deaths in Singapore. That gives a case fatality rate of about 0.15%. So hopefully we can continue to maintain a very low fatality rate in Singapore. Now coming back to Delta variant, we learned quite a fair bit from the recent outbreak. It is a highly transmissible variant with a very high viral load shedding in the respiratory system. And it causes more severe clinical illness in our own local setting. If I were to compare unvaccinated individual this year infected by Delta variant versus last year. And we experienced quite a sizable number of cases with vaccine breakthrough, despite vaccinations, full doses, 2 doses, and we use predominantly mRNA vaccine in Singapore. And of no surprise, the Delta variants behave very similar to the ancestral strain, affecting mostly the older individuals with severe clinical illness. So this recent surge of Delta cases in Singapore, I believe largely because of the very early introductions of the vaccinations, particularly to the older individuals. And we documented a progressive drop of neutralizing antibodies over time. Plus the nature of Delta variant, we also realized that the neutralizing capacity of our post-vaccination vaccine in fact dropped significantly. That could have added on and fueled the Delta variant outbreak in Singapore. So here we are in Singapore. We have now recently introduced booster program. We are now boosting the older individuals. And the Singapore government decided that we will then extend the booster campaign to cover all the frontline workers, including healthcare workers, and up to the age of 30 years old of adults to be given the booster. So we do not know the effect of booster at this point in time in Singapore. We largely look at the information and data from Israel to decide on the booster campaign in Singapore. So there remain a few questions in our mind, and perhaps it is a good case study to understand the durability of the booster and also attempt to answer these questions in terms of whether 2-dose booster with the natural infections versus 2 doses of primary vaccinations follow up with booster, which one would in fact give a more long-lasting protections in the populations. So that is my very quick updates in terms of the COVID-19 situations in Singapore. Thank you.
Thank you so much, Professor Leo. Really interesting to get that real information from Singapore. Fascinating to hear how a success in the early stages in terms of being one of the first countries to get the vaccination, very high uptake, is actually leading to problems now in terms of kind of waning protection. And as you said there, we're not out of this yet. So you're now going through the booster program and asking questions around what's going to be the most sustainable strategy going forward. So I think it's a real good case study, as you said, in terms of how can we learn from each other about what works and where do we go next globally in terms of our strategies going forward. Thank you so much, Professor Leo. I'm now going to invite Lisa. Lisa, for your comments.
Hey, thank you. Thank you for having me. It's an honor to be here with everyone today. My segment's a little bit different. I'm talking about a technology. I work for a technology company. So the technology that really helped the US, fight the COVID-19 variants. And what we really did is the technology took a lot of the administrative burden off of the staff to allow our staff and our healthcare workers to really concentrate on the patients versus the day-to-day activities. So, unlike most of the European countries, US is a very disparate system of private providers and insurance with a third-party system. And that comes with a very administrative financial burden. 34% of the total cost in 2020 was administrative expenses. And that's due really to the labor. We have to have a lot of labor to produce such information. Like Jessica was mentioning earlier, how many tests, COVID tests did we give? How many of those were positive? How many of those were negative? Tracking the number of vaccines and doses, all that information is very difficult for the US because we have so many different software systems that don't talk to each other. So how do we get a good handle on, the COVID outbreak and where we are today and how we are succeeding? Really had a lot to do with the technology that we started to employ. So, COVID-19 really highlighted all the issues with our, technology infrastructure. And typically it would take 9 to 12 months for our healthcare companies to make to vet the software, make a purchasing decision, and then another 6 to implement it and get it up and running. And really COVID, made timing an issue. And we had a lot of people gravitating towards this type of technology. A lot of the reason is our CEO extended free software to the healthcare companies in need. So a lot of them did reach out and say, how can you help us? What can you do for us? Because we're already overburdened. We've got staff burnout and, clinician burnout, and we still have more patients coming through the door. So next slide. So thank you. So just a quick step on, what's the software and how did it really help? Well, it's a technology that makes software robots that emulate what a human can do. So anything a human can do with respect to the computer, like the clicking, is what these software can do. So it can open an email, it can extract information from the email, and it can put it into an Excel spreadsheet, and then it can do some calculations, and then it can email it to someone else. So, it can scrape data from the web, it can log into applications and all that clicking on a computer that a human would do. So the processes that really lend themselves to this type of software are those that are highly repetitive, manual in nature, very rules-based, and has low exception rates. And we call those swivel chair activities. So if you think about two systems, especially in the healthcare world, that don't talk to each other and need to take information from one and enter it into another, that's a perfect scenario for RPA. So the next slide, how did that really help? Thank you. Within, the COVID-19 scenario. Well, again, trying to get all that information. Our first scenario is regulatory reporting. Here in the US, we have to report all of this information to our local governments, the state governments, the US government, the CDC. So all of our systems did not connect. And so we had tons of people just sitting there, entering this information by hand. So we were able to use RPA to extract information out of these systems and upload it to all the websites, really taking that out of the hands of the care providers. The scheduling of vaccines, we opened up a lot of different methodologies for patients to schedule their dose or to schedule their vaccine. And there was a lot of manual prioritizing, are they of the proper age? Is it time for them to get it? And then once they got it, it has to be documented somewhere. So, did they have a physician that they normally go to? What insurance company? So all that information led to a lot of reconciliation of data post the fact of getting the vaccine. So we have a lot of scenarios where we've implemented RPA to do some records reconciliation. Same with the mass vaccine administration. So we were setting up large infrastructures, thinking about, we were using, arenas and large parking lots to really just have a massive number of patients, vaccinated at once. Well, we need to document that in the US. We need to document the fact they came for the visit and they got a dose. So training these people, all our volunteers, on how to use a system that they've never even touched before was a big jump. So again, using RPA, patient would come in, present some identification, get it verified, and then RPA would take over and document all that information, could reconcile it again on the back end. And supply chain management really worked well in supply chain management, managing PPE, understanding, where the shortfalls were, doing a lot of the integrating of the vial and the batch data reporting and the manufacturing reporting and the length of the backlog. So, those are just some use cases where our technology, as we extended it to all our healthcare workers, really helped reduce the clinical and staff burnout, allowed them to deal more with the patients and not so much with, the administrative stuff. And the information is more quality. It's because there's no human errors. It's more timely. We created interoperability between systems, and really the time to value is we could set these up in like 2 to 4 weeks. It's a really quick process to get these in there, and they're flexible. So once one problem was a high volume and it got to something manageable, we could take the software, apply it to the next issue that really came up that was of critical concern. So, that's kind of my perspective on what our company did, because again, we're technology, so that's what we did, and that's my pitch for today. So thank you very much.
Thank you so much, Lisa. As you say, a different perspective, but really interesting to hear, because I think a lot of our audience, there'll be civil servants, public servants from around the world. A lot of those things that you mentioned will really resonate with them in terms of anything that can help reduce the burden, especially when you have something like a pandemic hit. You've suddenly got to do so many different things on top of keeping all the other public services going. So as you say, automation can be used to remove a lot of those routine administrative tasks so you can focus people on priority tasks. And just setting out there those things, I know lots of civil servants will have been working on those things in terms of how they dealt with the pandemic. So setting up different systems, connecting different systems, just processing vast numbers of patients, using data in different ways, managing a completely new vaccine system, all of those things really, really important. So if any of the audience have questions about that, please do message in those kind of questions as well. Thank you so much, Lisa. I'm now going to invite Maria, Dr. Maria, to give us her comments. Over to you, Dr. Maria.
Thank you, and hello to everybody across the globe and to my co-panelists. I will be discussing about what we have done in the Philippines regarding vaccination. Next slide, please. So I will be beginning my discussion by giving a brief situation of COVID-19 in the Philippines. The Philippine population is currently around 110 million. As of October 18, the total reported confirmed COVID-19 cases in the Philippines is at 2,727,286, of which 2.52% are active cases, 95.98% are recoveries, 1.49% are deaths, which is lower than the global case fatality rate of 2.06%. Looking more closely at our active cases, 93.63% of these are either asymptomatic, mild, or moderate, and 6.37% are severe or critical. Next slide. So let me just underscore the guiding principle of our government's response against the pandemic. The crucial concept of COVID-19 is to embrace that the endeavor is the one that requires a joint effort between the national and our local governments, and that it should espouse a whole of government, a whole of society, a whole of system approach. Therefore, all necessary information from all sectors are welcomed, including those from the non-government partners and the civil society. Next slide, please. In order to arrive at the decision point for our vaccination efforts, we have partnered with various group of experts to discuss current data from the viewpoints of health, economy, and social aspects. We have convened holistic and inclusive group of experts composed of physicians and scientists in the field of public health, microbiology, vaccinology, pediatrics, infectious diseases, epidemiology, as well as sociology, anthropology, and economy, to name a few. The slide summarizes the process for adopting interim guidance from expert groups in our national policies. Next slide, please. In the context of scarcity of vaccines in the Philippines, vaccines were given first to those with higher risk of exposure and death. This is our COVID-19 vaccine prioritization framework. For Criterion 1, the identified priority group shall be given access nationwide. If the incoming vaccine supply is less than the number of people in the population group selected for vaccination, there will be further prioritization based on Criterion 2. Our Criterion 2 will be, we consider the geographic location based on the COVID-19 burden of disease and the local government's readiness to effectively and efficiently deploy the vaccines. For Criterion 3, we consider sub-priority groups based on exposure and mortality risk. With this criteria, we have started our vaccinations first with the workers in the frontline health services. They are the A1. We have A2, who are the senior citizens, A3, persons with comorbidities, A4, frontline personnel in essential services, and A5, the indigent population. We now have started to vaccinate other workers and special populations. Next slide, please. Currently, there are already 8 COVID-19 vaccines that have been granted emergency use authorization by the Philippine Food and Drug Administration. While there are differences in the way these vaccines bring about immunity, all have already been proven to prevent severe infections, thus reducing mortality and potentially easing the strain in our healthcare system. Next slide, please. As of October 17, 2021, there had been over 91.5 million doses of COVID-19 vaccines delivered to the Philippines via donations and procurement by the Philippine government and the private sector. There are also 8,147 vaccination sites all over the country, with no vaccination sites reporting reduced capacity in all areas with high number of COVID-19 cases. Next slide. With our vaccine priority framework and our updated COVID-19 policies, I would like to give all of you an update of our Philippine COVID-19 vaccination. As of October 18, we already have administered over 52.7 million doses of the COVID-19 vaccines. There are now over 24.4 million Filipinos, or 22% of the population, who are fully vaccinated from our 5 priority sectors: the healthcare workers, senior citizens, individuals with comorbidities, frontline personnel in essential sectors, and the indigents. Next slide, please. The most commonly reported adverse reaction for all vaccines include headache, fever, and injection site pain. In a report released by our Philippine Food and Drug Administration on October 10, among 49.6 million vaccinations, only 0.14% were recorded to have adverse events following immunization, and 0.134 or 0.13% are considered non-serious adverse events. Only 0.006% account for serious adverse events in the Philippines. This undergo proper causality assessment by our experts so that the appropriate response may be enacted. In cases involving deaths, it was found that most cases involved people with existing comorbidities and that most cases were coincidental in nature. None of these deaths had been caused by the COVID-19 vaccine. Next slide, please. Part of the implementation of our vaccination program is continuous evaluation. Data-driven decisions are highly valued in improving our campaign for vaccine confidence. This is why the national government has been regularly conducting surveys, focus group discussions, and online analytics. We also welcome independent survey findings. Based on the social weather survey for the first and second quarters of this year, in May of 2021, only 32% of the population were willing to be vaccinated. This increased to 45% by June of 2021. Next slide, please. Here is a table from Organic Intelligence that summarizes the different polls on vaccine acceptance in the country. From Pulse Asia's February poll before the vaccine rollout, vaccine acceptance was at 16%. This increased to 43% in June. YouGov had a pre-poll survey that showed 45% acceptance that steadily increased to 68% and 75% at the end of the second quarter and the end of the fourth month of our vaccination rollout. Next slide. Despite the increasing trends in vaccine acceptance and having fully vaccinated about 22% of the population, a lot still need to be done and improved. And we learn from our experiences, and we are giving this different advocacy campaign so that we can be able to increase our vaccine confidence in the country. Next slide. We have a multi-sectoral approach, even in improving our vaccine acceptance and confidence. Private sector is helping out so that they can provide this kind of information to the public. Next slide. And this will be my last slide. Vaccines for the longest time had been proven to be cost-effective measure in fighting public health threats. And these vaccines in the Philippines had proven to prevent the severe forms of COVID-19. It has decreased overall mortality, and it has decreased the strain in our healthcare system. Thank you very much to all of you, and good evening and good morning to all of you.
Thank you so much, Dr. Maria. Again, really great to have a perspective from a different country. As you say, there are lots of good work being done in the Philippines, but you also set out some of the challenges that you face there. So still a relatively low number, percentage in terms of fully vaccinated, so at around 22%. But good to see the data going in the right direction in terms of confidence growing in the vaccine, so overcoming some of that hesitancy. But as you say, still more to do, and you're focused there very much on education of the population. And I think you mentioned some things that we'll probably pick up in the Q&A as well, the public and private sector working together, the different ways that you approach prioritization. So all of those things, I think, have been echoing what other panel members have said. Thank you so much. And now, last but not least, we will go over to Heather. Heather, over to you.
Great, thank you very much, and very interesting presentations thus far. I'm just going to focus on the planning and the logistics challenges that we had in Canada as we were preparing and then eventually implementing our rollout. So the next slide. So when we started actually our planning, it was dovetailing on significant investments that were made by the government in Canada in order to be able to secure the availability of vaccines. And so for the vaccines that were under development, there were partnerships with our research community, but we had no domestic manufacturing. So there were 7 vaccines that were eventually actually included within our advanced purchase agreements in order to secure a number of different platforms, because at the time when these agreements were made, it was very difficult to be able to determine which vaccines would actually make it in terms of availability, as well as ensuring that we had contributed to de-risking some of the production that needed to happen, or the manufacturing at risk while the vaccines were in development, because as they were approved, we would want to be able to use them. But because there were 7 vaccines within our portfolio, in taking a look and a review, most of the vaccines had very different technical specifications and requirements related to the storage, transport, and handling, as well as administration. So as a team, we actually had to develop strategies for each one of the vaccines within our portfolio. We knew that there's, in terms of the progress with the clinical trials that we were monitoring very closely, and our discussions with the manufacturers, we had a sense of the timelines as far as availability. And as we were starting to review in deeper detail those challenges, it was the ultra low frozen temperatures and even the frozen temperatures that would prove to be quite challenging within the Canadian environment, largely because our immunization systems, which were very strong in Canada, they were largely built for 2 to 8 degree vaccine distribution and not for frozen. So there was limited capacity in Canada, but that was something that we had to build up in a very short period of time. Second to that was just the timing as far as when those products would be approved and available, and how many doses that we would actually receive ultimately. And so as other presenters had commented on, we needed to develop a strategy based on a very supply constrained situation, looking at a prioritization and allocation framework that would be able to meet the needs of Canadians who are at higher risk. Interestingly, within our environment, because we have such a large geography here in Canada, populations that were identified at risk included those who were living in remote or isolated communities. So those were communities who may have difficulty reaching or accessing healthcare. And once the virus started to, or once the virus was introduced in those communities, it could be quite devastating. And so that was part of our prioritization framework as well, that we needed to actually ensure the infrastructure and the supply chain could support reaching populations that were hardest to reach right from our initiation. And the last point I'll raise is that just as was the experience in Singapore, what we were tracking was for availability, for approval and availability as early as December. And for those of us who know us well or have traveled in Canada in the wintertime, that was another challenge that we also needed to conquer, was being able to reach the hardest, to reach populations in the wintertime. So what was included in some of the planning was the use of boats, planes, as well as the possibility of dog sleds and snow clearing machines for being able to reach remote communities. And so we had a lot of innovation in a lot of the strategies that were being built early on. So the next slide. So one of the capacity and capability of our infrastructure was a key issue that we were building up. And I would have to say as well, just looking at our portfolio, what we had difficulty being able to see was how long would we need to actually build up our infrastructure for the ultra low temperature chain. So would we, or what we were anticipating is that would stability change over time? So how many freezers did we actually need to have available and right at the point of administration? Or could we actually manage the vaccine at main depots and then be able to support the distribution? Very early days, it was, we were learning as we were going, and that included, working very closely with the manufacturers just to understand the stability of the product, how to manage it appropriately, and that included the movement of product. So as we were starting to look at our planning and some of the strategies that we were deploying to build up our supply chain system, we also needed to anticipate that at some point in time, we may reach supply abundance. So we started with supply scarcity for the first few months of the rollout. But as I said, at some point in time, given the portfolio of vaccines that we invested in and how we were tracking the development of vaccines, there was a risk that we may have an onslaught of vaccines, and would our system be able to handle that? So we created a vaccine forecasting dashboard, not only looking at demand indicators as well as those supply indicators, but we also included administration and what is the level of, or what was the anticipated level of health and human resources that would be required in order to be able to administer the vaccine within a week of that supply being available. And so we made this dashboard in collaboration with colleagues in Health Canada and Statistics Canada in order to inform the planning that was happening at the provincial levels, so that we could ensure that there was adequate health and human services available in order to actually administer the vaccine. Next slide. So as we were managing the rollout, it's the provinces and territories in Canada that have the responsibility for healthcare delivery. So a lot of the hard work was in the hands of our provincial and territorial colleagues, with the support at the federal level in order to be able to identify risk and risk mitigate and actually do tabletop exercises in order to play out some of the risks that may ensue. So the biggest challenges that we encountered, and we still do as we continue to manage the rollout, is a lack of visibility and predictability. This is where we are right now in terms, this is where we were and where we continue to be as far as the rollout. And as the colleague from Singapore had identified, is being able to keep abreast of the science and being able to understand where we need to go next as far as booster dose administration, as well as pediatric indications as we continue the COVID-19 rollout. So is visibility and predictability is perhaps the biggest constraints that we ultimately encountered. Next slide. But it also presented opportunities for support. And so leveraging private sector and nonprofit partnerships, we had a lot of innovative strategies that were used in order to be able to maximize the campaign activity that was going on in jurisdictions, as well as very focused efforts in order to reach the hard to reach population. This may include geographic barriers that I indicated earlier, or it could be populations that are in urban settings that may have difficulty being able to access the healthcare system, whether due to language barriers or the timing of the services are not well aligned with the way the family's work schedule may have been prohibitive to them, or just being able to reach the mass immunization clinics. So mobile clinics and other strategies, home-to-home or house-to-house services have also been deployed. Communication, I think that's been mentioned previously as well. So communication, transparency, information sharing, what do we know, what don't we know, and how are we working to be able to ensure the confidence of Canadian populations. And as well, we had reinforced webinars, training, support to a multitude of volunteer services, as well as health and human resources, in order to be able to shore up the resources available to support the administration. As I mentioned, we did have a surge as far as supply availability in around the May-June period. And so we had to temper that with the supply availability, with populations that were presenting for their first and second dose, as well as strategies that we deployed in Canada with mixed schedules, as well as the change in interval from first to second dose, and ensuring that Canadians had a good understanding of what those recommendations were and how to actually access services. And so the last slide is just an overview in terms of our deployment to date. We had 64 million doses delivered. And the one thing I will mention, because of Jessica's earlier comments, we are actually very thoughtful in the whole rollout. We did have a scarcity situation for most of our rollout until the May-June period, where there was availability of supply. But along the way, what we've tried to do through centralized coordination and distribution is monitor very, very carefully what the needs and requirements are in the provinces and territories, ensuring the vaccine is there for opportunistic immunization, but not to oversupply in a situation where we're at risk of wastage. So we've been monitoring that very carefully and very closely, and we'll continue to do so that we're meeting the needs of the population to have the maximum number of people access vaccines, and at the same time temper this so that we're not in a situation where there's waste within our borders. So with that, I'll pass it back to you, Sean.
Thanks so much, Heather. And again, I think it just shows we've heard from 3 countries there in particular, and each country, I think, has its unique challenges in terms of their vaccination program. So really interesting to hear from what you said about not only needing to invest early because you didn't have domestic production, but then those issues around logistics, weather, geography, remoteness of your population, all of those things coming into play. And it's interesting, I think we have a few people in the audience who are involved in transport logistics. They will be quite interested in some of the things you were saying about different methods that you had to consider and different innovative ways of delivering some of those vaccinations. thank you to all of our panel members for their brilliant opening remarks. I think that's really set the scene fantastically for our conversation. We've already got questions in. We're going to have to keep the answers quite brief, I'm afraid, just to get through as many of these questions as we can. But I just want to kick off. I mean, you mentioned there both, I think Professor Leo and Heather, you were talking about the future, you know, and what have we learned in terms of the future. So I just want to ask you all very quickly to get the conversation going. Do you think, knowing what you know now, that we are in a better position if we were to go into another pandemic in future? So what have we learned that will set us in better stead going forward? Are you optimistic for the future? Professor Leo, I'm going to start with you first. I'm going to mix the order up a little bit. Professor Leo.
Well, I would say that I certainly hope so. I think at many of all these global conferences, this is a very commonly asked questions, whether we will be better prepared for the next pandemic. I think most of us honestly will say that still a lot of work needs to be done to make sure that we can be better prepared for the next pandemic. Just to share a little bit about the experience in Singapore, because we have been through multiple episodes of outbreak, including the 2003 SARS outbreak in Singapore. So a lot of the drawer plan, in fact, took experience from the SARS 2003. And for that reason, Singapore decided to invest quite a hefty amount to beef up the preparedness capability, including building the brand new National Center for Infectious Disease. So you can see the building behind me. It is a purpose-built isolation facilities with all the medical facilities available within the building, and 3 laboratories and the whole suites of all the necessary facilities in that particular building. Now, what had happened was that we, based on the year 2003, to give the estimate size of the future epidemic and pandemic. So we decided to build a building of 330 beds with the ability to scale up to 500 beds. So when SARS, COVID-19 came to Singapore, at the early days when we had to respond to the first wave of the COVID-19, I was asked several times whether the facilities would be adequate to handle. And my answer was very, very simple. It will not be adequate to be able to handle COVID-19. And indeed, so we had to change the strategy from having a centralized outbreak management center, having all the cases in a National Center for Infectious Diseases. We, in fact, mobilized the entire healthcare system, where all the public acute care hospitals were required to take in COVID-19 cases. So I think it is good to be prepared, but at the same time, I think it is also good to be flexible in the system.
Yeah. Right. There's always a danger that you're kind of fighting the last war, isn't there? And that the next thing is always a little bit different. So, Dr. Maria, I want to come from your perspective. Do you think the Philippines would be better prepared next time? Do you see positives that have come out of this in terms of preparedness for the future?
Yes, thank you for the question. Actually, this pandemic has exposed our vulnerabilities, and no country was really prepared. But yes, I can say that we can be better prepared next time because we saw the existing gaps in our healthcare system. When we started off with the pandemic, we only had one laboratory that can confirm the results of the test of a COVID-19 positive. We even sent samples to be confirmed in Australia during the first month of the pandemic. But now we have almost 300 RT-PCR laboratories in the country. When we started off with the pandemic, we only had one quarantine facility, which were just catering to our overseas Filipino workers who were coming home. Now we have more than 100,000 beds for isolation and quarantine. So having said that, we also have instituted, there is this bill in our legislature for a Philippine Center for Disease Control, just like what Singapore has and the other countries has, so that we can better manage and we can have centralized expertise when in terms of pandemic. And also we have now being instituted a virology institute where we will be starting the fill and finish for vaccine manufacturing, so that we can be able to be more independent as when another pandemic comes.
Thanks, Maria. Lisa, so it's clear from what we've heard there that countries are developing their expertise and bringing together, deepening their capacity to deal with future pandemics. Do you think technology will play a part in kind of helping people to be better prepared going forward?
It's going to help them be more prepared from a data aggregation standpoint. In the beginning, we were really struggling to know how many tests we had out there, how many people were dying, where are the pockets. But once we were able to get a handle on that information, we could see, hey, we need more vaccines here versus here. We need a different logistical structure to get them out to the rural areas. So, and with respect to my specific technology that we sell, it's very flexible, so you can dismantle it and recreate something else to handle sort of the next emergency, if you will. So it's a great support tool in that respect.
Yeah, and I guess people having used it now will see its benefit for the future.
Yes.
Heather, you spoke very much about kind of not having that capacity in Canada to do the distribution. Do you think that's something you'll be better prepared for if need be in future?
Yes, I think that's fair to say. I think for every country, I don't think that Canada was unique in this experience, is that, you have your infrastructure and you have your system for routine immunizations, and strengthening those systems, I think, is going to be critical as we go forward to be prepared for any kind of future event. I would say I would have to absolutely concur in terms of flexibility, because you have your line of sight in what you expect, and then I think what this experience has taught us is that also expect the unexpected within your systems. But for all of us, I think the opportunity to be able to review our systems, the strengths of those systems, identifying where those gaps are, and the opportunity to be able to address those gaps has provided us a great opportunity as we go forward in the future. Perhaps there's innovations in vaccines and vaccine development and other life-saving commodities that could benefit from this experience.
Thanks, Heather. Jessica, I wanted to come to you last on this first question, just because I wanted to ask, you gave quite a stark kind of overview of the situation in your opening presentation. Have you seen anything that makes you a bit more optimistic that the global response would be better next time round?
It is a tricky question, because I have to say my instinct is not optimistic. I think it was the current Secretary General of the United Nations who said, we've excelled on the science, but we get an F for ethics on the global vaccine rollout. There's really been a real inability to collaborate for the global good demonstrated through this pandemic. I think grounds for optimism come in the coalition of countries working together to try and change the status quo on issues like intellectual property rights for medical technologies, specifically for the COVID pandemic. So we've seen a lot more kind of collaboration and a strong civil society movement behind mechanisms to change what's happened for now and for the future. But I really hope that for the next pandemic, we're learning from this situation of vaccine inequality. We're developing manufacturing capacity now across regions, so it isn't just concentrated in small pockets of the world. It's encouraging to hear that example from the Philippines. We're learning to develop a real global plan at the outset with targets that are stuck to on vaccine rollout. And also that we're learning the lesson on governance and inclusion, because I think part of the problem with this pandemic has been some of the global governance of structures like COVAX has been skewed towards a historic way of thinking, really, in terms of traditional donors dominating discussions and companies setting a lot of the terms. So I would hope that in the future we're building much stronger representation of lower middle income countries into those structures.
Thanks, Jessica. We've had a question in particular for you on the IP waiver issue, but if it's all right, we'll pass that to you behind the scenes because it's a very specific question and maybe you can take that afterwards. Thank you. So we had a couple of questions in from different audience members. Please do keep your questions coming as well to the audience now. But I want to ask this one from Chris Lentz, who comes from Canada. And Chris has said that fear, so vaccine hesitancy, appears to be a very big issue still in lots of countries in terms of the take-up of the vaccine. And he's saying, is there any research been done on what's the most effective way of communicating to the population to overcome that hesitancy? So from your own experiences, what do you think works well in terms of overcoming that hesitancy? And do you know of any research maybe that's been shared going back to this collaboration in terms of what works well in terms of driving up uptake? Dr. Maria, I'm going to start with you because I know you've got a big focus on this because it's quite an issue in the Philippines.
Yes, thank you. We have not have any kind of research about this, but there had been surveys wherein they were able to ask the participants of this survey what were the causes why they didn't want the vaccine. First would be we had the dengue vaccine issue in the Philippines in the past years because of this new vaccine for dengue. Then the second one would be their hesitancy because of the side effects, apparently, the adverse reactions coming from the vaccine. And the third, I guess it would be because this COVID-19 vaccine is new. But what we have done so far, we have conducted different town halls. We tried to address them, different audiences at different scales of information that we give them because these were the major things that they do not understand and are afraid of. So we were able to address that. And after these specific town halls, we were able to see that after the last survey, confidence had improved. But of course, there are still a lot of work to be done, especially now that there are a lot of anti-vaxxers even here in the Philippines.
Yeah, thank you. Lisa, actually, I'm interested. You gave some examples of where automation had been used in the pandemic. Is there a role for automation on the communication side of things? And as Dr. Maria mentioned there's a lot of misinformation in social media, for example, on the internet. Is there a role for automation in countering any of that kind of information?
Absolutely. Where I think it could be, yes, best used is, it can push out information. We did have a hospital that was, physically calling patients and giving them the results over the phone, if that's the method that they wanted it. But also I was thinking about, it could do some mass, communication efforts and push out information to huge numbers of people at once through various channels. We do it now through Twitter and LinkedIn and all of these, the other social media on, why vaccines are important or whatever the message is that you're trying to get out to, get these people. And obviously the tracking of who opens the messages and who reads them and do they get forward. There's a lot of those tracking mechanisms. So again, that automation can take that burden off of everyone else and just continue to put the message out there for the, the population so that we can try to allay their fears and hopefully get them vaccinated.
Thanks, Lisa. I know for a lot of countries, overcoming a lot of that misinformation that has become a task in itself, taking up a lot of resource. Heather, you're nodding there. Do you have any kind of experience on what's worked well in terms of overcoming vaccine hesitancy? And the questionnaire actually goes further and said, should it be a kind of fear-based campaign, or is it more flip it around and it's a kind of positive, these are the positives of doing this rather than focusing on the negatives of not being vaccinated?
Yeah, I get one comment is that I'll stay in my lane. My expertise is around the vaccine logistics and distribution and supporting administration. But I think from that perspective, what we have spent a considerable amount of time doing and supporting is around transparency of information. We still maintain very, very close communication with all of the manufacturers so that we have a good understanding of any changes within the product. We ensure that we're communicating that to our provincial and territorial partners and support webinars, education seminars for healthcare workers and providers and other public health experts within the field in order to make sure that, you know, we're demystifying information about the vaccine, arming and preparing our healthcare workforce with the latest of information, and maintaining that transparency and that level of communication, even with the Canadian public, so that we can address their questions and concerns. And so I think, just reinforcing that transparency, communication, and having information available, and that continued support, because that was the one thing that we noted throughout the whole rollout, was that information was changing, and it was changing quickly, and being able to be fair about what we knew, or what we know, and what we don't know, and what we'll continue to pursue and be able to communicate. So I think from that perspective, that's, it was one mechanism. I guess the only last thing I would say, it's multifaceted. And I think that's the other thing that we've learned throughout this whole pandemic response. It's multifaceted. It's not one solution, it's many.
Yeah, thanks, Heather. Jessica, the issue of communication and hesitancy, is that something that Chatham House and you've looked at in terms of differences? Does that make a difference in terms of some of those inequalities that you see?
I would have to say it's not my area of expertise. It's not something we're looking at Chatham House. But what I would say on hesitancy is it's often used as a reason, and has been notably cited by the CEO of Pfizer in the not too distant past, as a reason for the problems with the rollout in low-income countries. And what I would just say on hesitancy is hesitancy can be a cause when there is supply. When there's no supply, hesitancy can't be the cause. Yeah. The supply has to be there, and all countries are grappling with hesitancy. I'm based in the UK. I have friends who have declined the vaccine, who I'm desperately trying to persuade to take it. So hesitancy is a problem everywhere. But if you've got the supply, then that is the absolute foundation of everything. And I also think there was a study recently done which compared hesitancy across different parts of the world, and actually found in the African countries that they looked at that the hesitancy levels were similar to the UK. I think it was, this is off the top of my head, so I'd have to double check, but I think it was around 80% uptake, as opposed to countries performing far less well on hesitancy, which were places like the US and Russia. So I would just, far too easy to use it, especially when it comes to low-income countries.
Thanks. Professor Leo, I know you've got a very high intake, but you did say there's a kind of stubborn hesitancy, particularly in some of the older population. So in your experience, what works well in terms of education and communication to try and overcome some of that?
Well, I think a lot of good points I had already mentioned. And I think Heather also mentions about multi-prong. Perhaps I just share some of the experience that we have had. So we decided to go ahead and deploy the mRNA vaccine, and it was very, very new. It was very difficult to explain to the entire populations what mRNA vaccine was about. And there was a lot of suspicions as to whether or not this is something that is good, is useful, toxic to the body. What had happened was that the ministry decided that we need to really collect good information and good data. And because we roll out the vaccines among the older population first, so you can imagine the difficulties that we had at that point in time, because we know that they are high risk. They may not really be the victims or be the side effect of the vaccine, but it could be just the natural progressions of the disease. And indeed, during the early rollout of the vaccine campaign in Singapore, we did come across some of the elderly folks, in fact, pass on within a few days after receiving vaccinations. From the medical standpoint of view, we were very confident that it was not vaccine related. But how are you going to communicate to the entire population that that wasn't the case? So we decided to collect quite a bit of information to just show that there's actually no significant change in terms of the trend of the mortality curve in Singapore. So this is one of the things that we had to go through. Now we do have a hard to reach population. Those hard to reach populations tends to be much older, and tends to be more homebound. And when we started the message to ask our older populations, senior citizens, to stay home, home seems to be the safest place. So many of them felt that they are homebound, they are just basically at home. The risk to them is actually just too low compared to the suffering that they had to go through with the vaccine. So those were basically the group that is really hard to reach. So what we have done is to send a mobile team. So even with the mobile team, some of them still kind of reluctant. So I think we can continue to push to the last mile vaccinations, but I think we will do what we can.
Yeah. Thanks, Professor Lee. I've got a very last question. I can't believe how quickly the time has gone. That actually builds on that, what you just talked there about the hard to reach population. But before I just come quickly to all of you on this final question, just to say to the audience, a questionnaire has just been sent out. It will be in your inboxes. If you could take a couple of minutes to fill that in, I would be hugely grateful. It just means that we can always give you the kind of webinars that are most useful for you. So thank you from me in advance. And our final question, I'm afraid, today comes from Michelle Legg in Australia. And she has asked about people with disabilities. So she said, we know that people with disabilities are particularly vulnerable to complications from COVID. She'd like to hear about any approaches that you are aware of in your country or elsewhere that have been particularly focused on helping people with disabilities to get the vaccination. And I'm afraid we've only got a few minutes left, so we'll have to keep the answers quite tight. Professor Leo, I'm going to come back to you, because maybe did you want to add anything that you said already about reaching those hardest to reach vulnerable communities when it comes to people with disability?
Well, I do believe that some of the populations that are hard to reach, in order to reach them, you have to go to them. So I think it is the mobilizations of the healthcare system to be able to cater to their needs.
Right, thank you. So going to them rather than expecting them to come to you. Lisa, was this something at all that came up when you were helping organizations during the pandemic?
Yeah, from an automation perspective, that's what we do. If all that information is gathered and it's very rural and it's very disparate, we can always, take that information and put it in the appropriate places, make those discrete notes. And so really help to continue to create those, personal health records for these people that are really in the rural population, and then really assist with the, state, local, and government entities to say, hey, we have reached out, we've got this many people vaccinated, and we're still working on some. So there's
really
definitely some applicability.
Using data and technology to get the insights into who does need this, who is the most vulnerable.
Yep.
Dr. Maria, is this an issue that you've had to deal with in the Philippines in terms of particular programs aimed at people with disabilities?
Oh, well, we have a particular program for persons with disabilities, and we have legislatures specifically focused on PWDs, as we call them. And in this vaccination program, we have these sectors that we have prioritized, and they were part of that. We had this A3 sector. They were part of those with comorbidities. And I agree with Dr. Leo that instead of waiting for them in the vaccination sites, we have these strategies that we can go to them so that we can give their vaccination. So we have a specific registry for persons with disabilities, and that was part of how we have been able to reach them for this vaccination for COVID-19.
Thanks, Dr. Maria. Jessica, I'm going to come to you. So within those inequalities that you talked about globally, did you look at also inequalities in terms of people with disabilities? Is that something you were focused on?
No, not at all, I'm afraid. But I would say we know that people with disabilities are often the most marginalized within a health system. And there's obviously extra efforts are needed to reach and build inclusive vaccination efforts there. But again, I come back to, if you've got 1% of your population fully vaccinated, the chances of it being the most marginalized are slim. So we've really got to crack the global supply issue is really the number one for me.
Thanks, Jessica. Heather, no pressure, but I'm going to come to you for the final word on this. So you mentioned about the hardest to reach geographically. Did you also prioritize hardest to reach in terms of, for example, people with disabilities?
Yes, that was part of the early prioritization framework. So although we had very limited supply, but it provided an opportunity just to concentrate those efforts and try to reach those vulnerable populations. I think very early days, and Professor Leo might have had the same experience in December. We were still learning about the stability and the appropriate handling of the mRNA products. And I think in the very early days, we had very limited guidance because we just had very limited experience in the studies that were being done by the manufacturers. So it was what was the biggest challenge for us at that point in time. We could identify the vulnerable populations, but being able to reach them with the ultra low temperature chain products with limited guidance around how to actually handle that product to safely be able to transport it and administer it to those populations. And so that's where I think for the first few weeks, that's where the biggest tension was for us, is to ensure that we were safely managing the product, conforming to what was known about the stability and the temperature chain of that particular product, and then trying to transport it to reach those vulnerable populations. So, those early days when you have a vaccine that you have limited data in terms of transport, storage, and handling, that's where the challenges were. But because we actually corresponded very closely with many different colleagues around the world, as well as with the manufacturers, all of that experience, we were able to learn from one another as well. So I just want to end with that comment. These forums and these opportunities to be able to share our experience, discuss with one another, and be able to learn from one another are critical to the success that's going to happen in countries for the safe rollout and distribution of vaccine.
Thank you so much, Heather. That's such a lovely note to end on, I think. I can't believe our time is up. I just want to say a huge thank you to the audience for sending in their great questions. Just to let everybody know, there will be a link sent round with the video from this discussion, so you can share it with your colleagues who weren't able to join today and watch it all over again if you want to. There will also be an article produced with the key issues from this discussion, and you'll be sent a link of that so you can share that with your peers as well. A big thank you from me to UiPath for being our knowledge partner today. And I just want to end on a personal note. Thank you so much to our fantastic panel. The work you are doing is literally saving lives around the world. So I can't say thank you enough. And it's wonderful to have such an expert and an entirely female panel, which doesn't happen that often either. So thank you from me. Thank you to everybody watching. Wherever you are, enjoy the rest of the day, the afternoon, or the evening. And I hope to see you all again very soon on another webinar. To Jessica, to Professor Leo, to Lisa, to Heather, and to Dr. Maria. Thank you and goodbye, everybody. Goodbye.